Hello, my name is Maitland, and I've been asked to give a little bit of a summary on our immune system to try to explain what might be happening in the setting of individuals that have connective tissue disorders, and then end up having a triad of dysfunction, including musculoskeletal complaints, neurological issues, and increased susceptibility to chronic inflammation. So I have no disclosures for this conversation. And I'd like to start out by saying what the role of our immune system is in maintaining homeostasis. And essentially, the main tasks that have been assigned is for tissue defense, recognizing insults, and then containing those insults. And then after the insults have been contained, the purpose of the immune system is also to help coordinate tissue repair. So in many ways, I'm going to borrow this phrase from a German philosopher, Peter Sloterdijk, who basically said that our immune system is an embodied expectation of injury and of systems of protection as well as healing. And there are many components to our immune system that allow us to stay well and can potentially contribute to disease if these components end up being lacking or underactive or overactive. So there are two components to our immune system. We have the innate immune system and the adaptive immune system. The innate immune system essentially focuses on the physical barriers, including the skin and the mucosal linings of the respiratory tract, urogenital tract, and gastrointestinal tract. Several proteins, including from the complement system, and white blood cells, including dendritic cells, mast cells, macrophages, and natural killer cells. In the adaptive immune system, which is essentially only found in vertebrate species, it consists of two subsets, the antibody compartment from antibody protection by B lymphocytes and cell-mediated immunity, which are the T cells, of which there are many phenotypes, but we're just going to stick with the general recognition that T lymphocytes are responsible for coordinating intracellular pathogen defense, as well as helping out the production of different antibody subsets. And the innate immune system is responsible for recruiting in the adaptive immune system after certain insults are not being controlled by local resources. So let's talk about the different characteristics of the innate versus the adaptive immune system. In many ways, the innate immune system is considered the first line of defense. They have receptors that recognize tissue damage or existence of inflammation that had arrived from a different part of the body. These cells have receptors that are essentially profiling receptors, don't have any immunological memory, like they don't increase their affinity and ability to detect other than their usual suspects, which have been problematic for humans for millennia upon millennia. In contrast, the adaptive immune system is what gets recruited in after damage is not being contained in the innate immune system following certain insults. We have essentially the second line of defense that gets recruited by the innate immune system. Unlike the innate immune system, the receptors that are found on B cells and T cells have the ability to mature and increase affinity and essentially generate memory cells. So the next time you encounter this insult, you'll have faster, swifter immunity to prevent infection and also stop impending danger before it actually causes symptomatic disease. So let's talk a little bit more about the innate immune system, which only within the past 10 years or so really has been getting more attention in order to understand the different responses that the body has to the myriad of insults that it can encounter from a moment-to-moment basis. So the innate immune system essentially consists of the epithelial lining, as well as several cell groups, including dendritic cells, mast cells, macrophages, natural killer cells, as well as the epithelial lining. This is to kind of elaborate that we have, the average adult has about 75 square feet of territory that's exposed to the external environment in the form of the skin and the tracts of the gastrointestinal, urogenital, and respiratory tracts. And right below the epithelial layer is the mast cells and dendritic cells. And essentially, these are the guards right behind the epithelial lining that's exposed to the environment. The dendritic cells are really important for helping coordinate signals to recruit in the adaptive immune compartment, while the mast cells essentially are the ability to recognize danger and then have resources to contain that danger and potentially call in more help. We also have the circulating proteins in the form of the different components of the complement system, which has been found in species lower than the humans and vertebrates, which have been also known to help identify pathogens and clear pathogens after there's been a breach of the epithelial barrier. So there are a better depiction of how our immune system recognizes danger, whether it's in the form of pathogens, physical triggers, including radiation, or chemicals, whether they're naturally occurring or manufactured. And right below the epithelial layer, again, you have dendritic cells. You have the ability to recruit in macrophages or natural killer cells. And it seems that the dendritic cells are the initial recruitment of the adaptive immune response, whether T cells or B cells. And when it comes to recruiting in different components of the adaptive immune system, we find that it's the epithelial layer that helps determine the differentiation into a pathway that mostly goes after eosinophilic targeted pathogens, such as parasites, or T2 low inflammation, which goes after intracellular pathogens, viruses, and bacteria. And it is the chemicals that get released by the injured epithelium that influences antigen-presenting cells, including dendritic cells, as well as mast cells, to help influence the differentiation of the adaptive immune compartment, either into a T2 high inflammatory cascade involving interleukin-4 and interleukin-13 gene sets, which then in turn recruit in eosinophilic inflammation, or into Th1, which is considered T1, or T17, T3 type inflammation, which is dependent on interferon gamma, as well as interleukin 17 gene set inflammations. And this has a tendency to recruit in more neutrophilic inflammation as backup if needed. Interestingly enough, the one cell that seems to get very little attention when it comes to the innate immune system in the mast cells. And I think that's just essentially how we've been taught about this cell population, typically in the context of allergic inflammation in the form of asthma, allergic rhinitis, or anaphylaxis. But interestingly enough, this cell population compared to neutrophils or lymphocytes, humans cannot be born without. And so they've been shown to play a very crucial role in the immune response, not only in tissue defense, but tissue repair. So I'm going to label these mast cells as the ideal first responders. They sit right below the epithelial layer, armed with an array of receptors that can not only recognize tissue damage in the form of pathogen receptors, or endogenous receptors that can recognize tissue damage, such as having interleukin-33 receptor or TSLP receptors, or can recognize the pathogens in the form of direct recognition through toll-like receptors, or indirect recognition either through complement receptors or antigens or microbial substances that have been bound by either immunoglobulin E or immunoglobulin G. Mast cells also bear major histocompatibility receptors that have the ability to communicate with T cells. So you can see in many ways mast cells can act as a master regulator of the immune response, depending on what receptors are or are not engaged. And then depending on what receptors are engaged, you'll have a differential release of chemical mediators. For instance, if you engage the mast cell through the toll-like receptor, you'll have a tendency not to see degranulation of mast cells, but increased secretion of interleukins and cytokines that has more of a febrile response, unlike going through the IgE receptor, which is typically causing symptoms that feel like it's a febrile response, and hence the misnomer hay fever. But actually, you have recruitment of eosinophils and chemical mediators like tryptase and histamine that may be released in order to contain the incoming pathogen and then potentially recruiting eosinophils if needed. Just to give you an idea of all the different types of chemical mediators that mast cells release, they are able to release chemicals such as histamine and heparin and platelet activating factor that can influence blood flow and angiogenesis. They can release chemokines and cytokines that will not only recruit effector cells, but also allow them to remain chronically activated at sites of active inflammation or infection. And then after the damage is contained, mast cells have the ability to release growth factors that help with tissue remodeling and repair. And I also like to point out that two of the enzymes, tryptase and chymase, have the ability to have direct antimicrobial effects as well as detoxification of toxic chemicals that may be derived from either parasites or toxic biomaterial that comes into contact with the human. And I wanted to reiterate here, all depending on what type of injury or perceived incoming danger, you'll see that the mast cells have the ability to recruit in neutrophils if it is a perceived bacterial insult, recruit in eosinophils, and a T2 type inflammatory response if it's parasites that are being perceived or detected. And then if it's a viral infection, you'll probably see cytotoxic T lymphocytes, NK cells, and NKT cells. And this is all differential mast cell chemical mediator release that influences the type of inflammation that's recruited following the various insults. And then I wanted to reiterate here that once the insult is contained, the mast cells have the ability to release growth factors and alter blood flow in order to help with tissue repair after the insult has been contained and cleared. So moving on to the adaptive immune response, I wanted to just reiterate with the innate immune response that you have a first line of defense in the form of the innate immune system with the ability to recognize pathogens based on a profiling pattern of pathogen-associated molecular patterns, and then tissue damage in the form of danger-associated molecular patterns such as the release of cytokines such as interleukin-33 or TSLP, heat shock protein as another example. The adaptive immune system, which I think most practitioners have more familiarity with, involves focus on T cells and B cells. And B cells, you're talking about the production of antibodies, which is a very popular conversation now in the setting of COVID vaccines, and whether or not you've made protective adaptive immunity to the various variants. But again, it's really important to understand that it's the innate immune response that influences what type of an adaptive immune response is maintained in individuals after they've had initial exposures to novel pathogens. So starting with cell-mediated immunity, we're now focusing on T cells. And typically, T cells have the ability to recognize close to 10 to the 9th to 10 to the 10th different types of antigens that have been digested down by antigen-presenting cells. And once it's digested and the receptors have led to expansion of T cell clones, both effector T cell clones as well as memory T cell clones, the effector T cell clones have the ability to help communicate to granulocytes such as macrophages on how to eliminate microbes that have been phagocytosed. They also have the ability to lend to production of different types of antibodies depending on what the insult is. So typically with viruses, bacteria, you'll see the production of IgG or possibly IgA if it's at a mucosal surface. And then when it comes to parasites, you typically see the production of IgE, all based on whether we see T2 or T1 or T3 type inflammatory cascades. Regarding the production of antibodies, we're talking about B cells. And a little factoid that I had learned years ago is the term B cells comes from bursa fabricus, where it is a connective tissue site in chickens that was first identified the production of immunoglobulins, which then are learned to recognize antigens, hence the term antigen to dictate what B cells and T cells recognize. B cells are primarily responsible for making the various classes of immunoglobulins, of which there are 5. You have IgG, IgM, IgA, IgE, and one that doesn't circulate, IgD. And the purpose of these antibodies really is to go after different types of pathogens, depending on where you typically encounter viral infections, parasitic infections, microbial exposures, and not only to be able to go after the actual microorganisms, but also products that are released by the microorganisms, such as cholera toxin or botulism toxin, or the S protein of coronavirus. And they also, the antibodies not only have the ability to block entry into healthy cells and also facilitate clearance, they also have the ability to target infected cells or target circulating pathogen materials by tagging these materials or the cells with antibodies, which then will be cleared by the reticular endothelial system. The one thing about the adaptive immune system that you need to appreciate is this response is slow. Typically is an innate immune system that acts in the initial response, and then you see within hours to days the recruitment of T cells and B cells that have the ability to help counter some type of infectious or inflammatory insults. But on repeat exposures, you see that the immune system has the ability to mature and develop much more specific immunity, that upon the second or subsequent exposures, you have a much better, faster, swifter increase of the adaptive immune response to help clear pathogens and prevent infection and ongoing inflammation. The mechanisms that have been shown to lead to this maturation and enhanced antigen recognition system by the immunoglobulin and T cell receptors is called somatic hypermutation. And typically, the tips of the immunoglobulin and T cell receptors are able to undergo rapid mutation and then be selected out for a greater affinity. And then will generate memory T cells and B cells that happen to be more rapidly engaged upon subsequent encounters. So with the adaptive immune response, you have higher affinity with more swifter specific antigen recognition with the presence of immunological memory. But in the innate immune system, it's all about profiling after detection of tissue damage from injured tissue called DAMPs, and then the detection of usual suspects via profiling by receptors that recognize PAMPs. There's no immunological memory, and you can see that, again, these are not as specific as compared to the antibody and T cell receptors that get generated by the antigen by the adaptive immune response. So it's a coordinated effort between the innate immune system and the adaptive immune system in order to prevent damage from mechanical wounding, various microbial pathogens, physical insults, or even chemical insults, whether they are naturally occurring or manufactured. And if the immune system is doing its job, you won't understand, you'll have a healthy homeostatic status. But what happens if the immune system becomes imbalanced, either underactive or overactive? And I would have to say within the past 50 years, we've seen an increase in the detection or appreciation of immunological deficiency disorders, as well as hypersensitivity disorders, both immediate hypersensitivity disorders and delayed type hypersensitivity disorders, which are typically called autoimmune phenomena. And this has all been in the setting of modern miracles, which have extended life and prevented such pandemics as measles, mumps, rubella, vaccines for strep, sanitation have all increased life, but it's also unmasked the ability of developing chronic inflammatory states that lead to different forms of disease, morbidity, and in some cases, mortality. I'm first going to talk about immunodeficiency, where we essentially don't know how many individuals are born with primary immune deficiency. We don't screen for it, but the term immunodeficiency was really first appreciated in the general medical population with the onset of the AIDS epidemic in the mid-1980s. Per last census, we have over 36 million adults that are infected with HIV and 1.7 million children. But what's even more discouraging is the major source of immunodeficiency worldwide is malnutrition. And then with our attempts to help individuals that have hypersensitivity disorders, we find that individuals who are being treated for inflammatory bowel disease, multiple sclerosis, other autoimmune phenomena involving the skin and joints, they have a tendency to be put on medications that are immunosuppressive and that open the door to individuals developing a secondary immunodeficiency, including some data that I hope to present at another lecture on the increased susceptibility of primary immune deficiency and possibly secondary immune deficiency in individuals that have genetically inherited connective tissue disorders such as EDS and HSD. Regarding primary immune deficiency, these are just general estimates from studies that have done blood bank studies or looked at retrospective studies in large healthcare systems. But at this point in time, it's estimated that the most common form of immunodeficiency is in the IgA department, where 1 to 300 to 1 out of 600 Caucasians are known to have selective IgA deficiency. A much more rare form of antibody deficiencies is common variable immunodeficiency. And as it sounds, it basically says if you have at least 2 of the antibody cell lines down, you're at risk for having this primary immune deficiency. And then you have one that's a little bit more controversial, and that's mannose binding lectin deficiency. But interestingly enough, it's estimated that at least 7% of Caucasians are lacking this protein that's instrumental in activating the complement system. So when it comes to immunodeficiencies, we find that individuals may be increased for recurrent infections, severe infections, or unusual infections. But in addition to susceptibility to infections, there's also a risk of autoimmune disease. And with ongoing tissue damage, there's also a risk of developing pre-malignant or malignant lesions. Some of the more common immunodeficiencies are in the antibody compartment. As I mentioned before, IgA deficiency is quite common. After that, it's having more than one immunoglobulin line down, such as common variable immunodeficiency. These individuals have a tendency to be at increased risk to infections from encapsulated bacteria, such as Streptococcus pneumoniae, Haemophilus influenza type B, especially in the respiratory tract. So it's not unusual to hear children having recurrent upper respiratory infections involving the ears or the pharyngitis or the throat, or increased susceptibility to pneumonia, both in pediatric and adult populations. There's also an increased risk for having parasitic infections such as Giardia and enteroviruses such as Coxsackie virus. Regarding individuals that are born with deficiencies in the T cell compartment, such as idiopathic CD4 lymphocytopenia or B cell deficiency, T cell deficiency, these individuals have a tendency, again, to have increased susceptibility to encapsulated bacteria, may have problems dealing with mold and fungus, certain DNA viruses, intracellular pathogens such as mycobacteria, and increased risk for opportunistic infections, which was probably more commonly heard about in individuals that had not well-controlled HIV infection, but pneumocystis and cryptosporidium were not uncommon presentations in individuals that had T cell deficiency. Regarding people who have insufficient numbers of neutrophils or autoimmune neutropenia or have phagocytic deficiencies. Again, these individuals have problems dealing with infections from bacterial organisms such as encapsulated bacteria, gram-negative bacteria, and intracellular bacteria such as mycobacteria. They also have problems dealing with Aspergillus in Canada. And then for those that have complement deficiency, it is known that these individuals, again, are increased risk for infections. Mannose binding lectin is probably more well known for causing increased susceptibility to infections if you have another concomitant immunodeficiency, such as an antibody deficiency. But mannose binding lectin and complement are also known for helping clear dead cells and dead material. And if you're lacking this protein, you may be at increased risk for developing autoimmune disorders as well. And lastly, you have NK cell deficiency in these individuals. Typically, if you see an NK cell population below 3%, are at increased risk for viral infections. So, unfortunately, we're not taught to screen for immunodeficiency, and outside of babies that are born with severe combined immunodeficiency, such as John Travolta, who portrayed the little boy in the bubble. We don't diagnose these individuals until years after initial onset of symptoms. And there are lots of different reasons for that, including the fact that we have a tendency to treat the symptoms and not understand what might be underlying their predisposition to developing recurrent infections. And a lot of it also has to do with education, in that we're not even taught to use this very simple validated questionnaire for identifying individuals that might be at increased risk for primary deficiency, whether or not you have a child that is being put on antibiotics more than 8 or more times a year for ear infections, a child or an adult that's dealing with deep skin or abscesses, individuals that end up having recurrent sinusitis within a 12-month period of time, the need to receive intravenous antibiotics outside of suspected Lyme disease or other parasitic infections. Some individuals, interestingly enough, will end up dealing with more than one pneumonia per year, which is also kind of a red flag to try to understand whether or not there's some form of immunodeficiency leading to this serious respiratory infection. And then also failure to thrive, both in children as well as adults. This is kind of just exploring some of the reasons we find a delay in the diagnosis of immunodeficiency. Sometimes patients have a tendency, again, just to treat the acute symptoms, but may not have the resources to know that they need to think about care beyond what their primary care physician has. And unfortunately, in this country, there are a lot of individuals that don't have a consistent relationship with a practitioner who can take the long view of what might be causing them to have recurrent or increased susceptibility to infections. Unfortunately, allergy immunology is barely featured in undergraduate medical education and residency, and unless you go into a specialty such as rheumatology, allergy immunology, or infectious disease, you might not be thinking that this person in front of you might be suffering from a primary immune deficiency. And unfortunately, there's a lack of presence of allergy immunology specialists in many hospital systems. In the US, there's only 80 training programs, so there's very little exposure to this discipline outside of textbooks, and typically taught by practitioners who are not necessarily in the specialty as well. And then even specialists may be in a healthcare system that does not allow them to think beyond the immediate chief complaint. As I said before, there is a lack of specialists, especially in allergy immunology. There's little over one allergy immunology specialist per 100,000 residents in the US. There's a lack of awareness of the variable presentation of individuals that have immunodeficiencies in the adaptive or innate immune compartments. And again, a lot of these patients may not have a family member who has a recognized immunodeficiency or has immunodeficiency that would say this is something that needs to be screened for. And also just to kind of lean into the fact that sometimes people with immune dysfunction will present with either immediate or delayed hypersensitivity disorders. These are these are some of the genetic disorders that have been identified where these individuals don't present with infections, but present with increased non-serologic inflammation. And then to give you an example of other more traditional autoimmune disorders that may be common in individuals that have deficiencies either in the innate or adaptive immune compartment, this was a retrospective analysis of over 450 patients who had the diagnosis of common variable immunodeficiency. This is from the lab of Dr. Charlotte Cunningham Rundles, one of our experts in the field of primary immunodeficiency. You can see that these individuals can have a myriad of autoimmune phenomena, and in the autoimmune phenomena may be the sole presenting syndrome, or it may run in the setting of recurrent or severe infection. So it could be anything from autoimmune thyroid disease, targeting other components, circulating red blood cells or white blood cells or platelets. Individuals are found to have multiple sclerosis, rheumatoid arthritis, or juvenile rheumatoid arthritis as well. So just to give you an idea, and this was early speculation almost more than a decade ago by Drs. Munoz and Mathis, showing that mast cells are not only involved in classic type 1 hypersensitivity reactions such as asthma, rhinitis, as well as anaphylaxis. But you can see, depending on what receptors are engaged, whether we go through the immunoglobulin receptors such as the type 3 response, we find in lupus or rheumatoid arthritis, or it might be going through the T cell receptor MHC complex on mast cells in the form of chronic dermatoses, asthma, as well as contact dermatitis. So as long as there's some form of chronic inflammation in the tissues or increased susceptibility to tissue damage, mast cells are going to be involved. It's just a question of whether or not they're leading the charge in the ongoing inflammation, or they're being chronically recruited in to continue with perpetuation of the inflammation in the tissues that are affected. In the past 50 years, we've seen some tremendous discoveries and public works that have led to control of pandemics that claimed many lives, including tuberculosis, measles, mumps, and rubella, hepatitis, HIV. We've had pharmaceutical and public work interventions that have been happening that have really helped save many lives and have extended lives of many individuals. But at the same time, where we're seeing increase in quantity of life, we're not necessarily seeing increase in quality of life with the onset of several immediate and delayed hypersensitivity syndromes, including inflammatory neuropathies, inflammatory bowel disease, neuroendocrinopathies, as well as delayed type hypersensitivity disorders of the respiratory tract in the form of rhinitis and asthma, or the skin in the form of contact dermatitis. I had the pleasure of returning to New York and working at Rockefeller University in the lab of Gila Kaplan, and had the pleasure of meeting some sentinel clinician scientists who were not only trying to tackle the growing pandemic of hypersensitivity disorders such as asthma, which was considered to be the #1 medical problem in the mid-1980s by Mayor Koch, who was the mayor of New York City at that time. But this announcement got trumped by the pandemic of HIV, which is the #1 well-recognized secondary immunodeficiency syndrome. And between these two pandemics, we started to get a great appreciation of how the immune dysfunction may cause or contribute to chronic disease. Interestingly enough, AIDS kind of reminds me of what's going on with the coronavirus pandemic, where in the early 80s, we didn't have a name, we didn't have a test, we didn't have therapies. And unlike 30 years ago, we are much more improved in responding with therapies that prevent the consequences of coronavirus infection, and also prevent hypersensitivity disorders, which is now plaguing several individuals who end up with coronavirus infection. So we understand that immunodysregulation can not only mean increased susceptibility to infection or having a bad outcome after an infection, but it also may predispose you to hypersensitivity disorders as well. And some of the hypersensitivity disorders that we've been seeing on the rise, including type 1 hypersensitivity disorders like rhinitis, food allergy, and anaphylaxis, but also delayed type hypersensitivity disorders such as thrombocytopenia, anemias, thyroiditis, multiple sclerosis, asthma are all on the rise. And a lot of the reasons that has been put forth really is focusing on the air we breathe, the food that we ingest, the clothing that we wear, the medications that we have a tendency to overuse, has changed how our body sees the environment every time we breathe, every time we ingest. The times that our skin which is always exposed to the environment, has changed the danger signals in our organ systems and the recruitment of chronic inflammation. And just to give you an idea of what chronic insults to the respiratory tract, gastrointestinal tract, skin, no matter where these insults are coming from, you can see any organ system can be impacted with exposures from the environment, whether you're causing generalized symptoms such as fatigue, malaise, or weight loss, chronic respiratory involvement, musculoskeletal issues, cutaneous forms in the form of flushing urticaria, angioedema, neurological, which is actually the third most common complaint in patients that have immediate or delayed hypersensitivity disorders, is suggesting ongoing tissue injury and chronic recruitment of inflammatory cascades. This is again to remind you that depending on how the epithelium lining is tickled and what part of the mast cell receptor cascades have been engaged, you can end up with chronic inflammation impacting any organ system, whether it's immediate hypersensitivity in the form of these disorders such as asthma, interstitial cystitis, pain syndromes, or headache disorders, but also delayed hypersensitivity disorders as depicted in this panel describing different autoimmune disorders involving each and every organ system. And I want to remind you that mast cells are not one-trick ponies. Again, depending on what receptors engage will lead to different distinct chemical mediator release patterns. So if you go through the IgG receptor, the MERG receptor, which is recognizes vancomycin, fluoroquinolones, you'll see the release of tryptase and histamine, which will cause these type of symptoms. But if you go through the toll-like receptors or the major histocompatibility receptors or the cytokine receptors, you'll get more febrile illnesses, which can cause neurocognitive compromise, vascular compromise, and gastrointestinal distress. And the patterns of chemical mediator release can be varied. So again, if you go through the immunoglobulin receptors, you'll have these granules released intact and make their way to the lymph nodes to influence the adaptive immune compartment. Or if it goes through the MERG receptor, you'll get a reaction like you see with certain antibiotics or anesthetic agents where the patients will have a degranulation event causing redness, cardiovascular compromise, or gastrointestinal distress. So why are we seeing an increase in these hypersensitivity disorders? There's a gentleman named Thomas Platts Mills who really has pointed out to how we live nowadays and the type of exposures that we're getting in our living environments, where what we eat, wear, put on our skin, or breathe in is influencing our organ systems to be staying on a permanent fight or flight stance and leading to increased recruitment of inflammatory cascades, causing chronic inflammatory disorders such as depicted in this graph. And I'm going to borrow from the multiple chemical sensitivity clinician researchers who talked about toxic exposures that lead to loss of tolerance in the immune compartments. They have put forth that there are certain individuals that have a tendency to have increased susceptibility to immune dysregulation from loss of components of immune cells or proteins that may predispose to increased susceptibility to inflammation. Environmental exposures, including the food diets that we have, and in this country, obesity has a tendency to lead to more immediate hypersensitivity inflammation. And then this ongoing chronic immune imbalance, along with aberrant tissue repair because of ongoing inflammation, will lead to the setup of these chronic inflammatory disorders, both immediate as well as delayed hypersensitivity disorders. This is a busy slide to just tell you that our worlds have changed quite a bit from 100 plus years ago to nowadays, but it really speaks to the fact that our gastrointestinal tract, our skin, our respiratory tract are now encountering variable climate, variable chemicals, whether naturally occurring such as mold or manufactured such as volatile organic compounds that are injuring the tissue. And the injured tissue is unable to provide a more hospitable home to microbes that are good for our health and lending to persistence of microbial matter that may be detrimental to our metabolism. And this in turn leads to ongoing tissue injury, inflammation, and aberrant tissue repair. I just wanted to put forth a theory where you have individuals that have a connective tissue disorder, a barrier issue, which is now being impacted by environmental challenges, whether it is an indoor environment where we spend more than 90% of our time in, whether it's an auto, a car, a school building. The type of foods that we eat, especially processed foods, which have a tendency to not to be good regarding the microbiota, and then our responses metabolically. And then also the air that we breathe, and the combination of the genes plus these type of toxic exposures is leading to the development of these chronic hypersensitivity disorders. So there's some individuals that have actually proposed that we should return to former living existence, whether we start exposing ourselves more to parasites, we start eating dirt, or maybe just less processed foods per a doctor's prescription to help bring better balance between the epithelium and this immune network, as well as the neuronal network that helps respond to the ever-changing exposures, physical, infectious, or toxic. And it's through these exposures that lead to the release of different chemical mediators that will influence our tissue immune response as well as our tissue repair. So in summary, we have a very complicated immune system that consists of two different subsets. We have the innate immune system, which is very old. Toll-like receptors were found on fruit flies in the 1990s by a wonderful scientist, Dr. Mesvitov in Yale, who expanded our knowledge about the role of the innate immune system and its impact on the adaptive immune system in recruiting T cells and B cells to help us remember pathogens that we've seen before and have a more swift response upon subsequent exposures. But the innate immune system appears to be what influences the adaptive immune system. So by maintaining a more healthier environment and reducing epithelial damage or border damage, then you will lead to reduced inflammation being recruited by the innate immune compartment and the adaptive immune compartment. And it seems that many individuals have a tendency to default with ongoing injury to this T2 type inflammatory response, looking allergic-like, but actually due to a lot of things other than allergies. And then with the innate immune response, you have the recruitment of T cells and B cells that hopefully builds more protective immunity like we might be seeing from certain vaccines, and not lead to immunity that's detrimental to our health and forming autoreactive T cells and B cells that lead to perpetuation of these immediate and delayed hypersensitivity disorders in the adaptive immune compartment. So with the ongoing inflammation, again, we also see aberrant tissue repair. So it's important for the inflammation to recognize the danger, clear it, and then stand down. And we see that's not the case in individuals living in a much more modern environment. So the take-home message for this talk, and I appreciate your patience in this, is that we have a complicated immune system that has been under unknown challenges over the past 50 years, leading to our ability to detect more individuals that are deficient in components of their immune system. That helps maintain a balanced immune system dealing with the external environment, or increase wear and tear. And also, we're seeing a pandemic of hypersensitivity disorders, probably predated the COVID pandemic, where we've had nearly 1 out of 2 of us living in modern environments have a chronic disorder, and either the immune system is driving the bus or is being chronically recruited to help perpetuate these pathogenic disorders. I want to thank you for your time and appreciate your patience in a microscopic view of the immune system. I have many people to thank, including all the patients that have entrusted me to try to pull back the layers of immune dysregulation that is occurring, especially in individuals that have connective tissue disorders. I want to thank my collaborators at the newly created Department of Immunology, Chiari EDS Center at Mount Sinai South Nassau, Dr. Bolognese and Dr. Ruhoy. And these are 2 wonderful books which address immune dysregulation, neurological dysregulation in individuals that have connective tissue disorders. I welcome any questions.